in-person face-to-face attendance was being discouraged. But in the second wave, with the collection of more data and with the impact that we have seen in the first wave, it has been recommended now that antenatal appointments should be offered in person and only when the pregnancy is considered to be low risk and there is no need for physical examination, only then remote consultation can be pragmatically be offered. The routine and standard antenatal care should be continued with inclusion of folic acid and vitamin D supplementation, influenza vaccination. The pregnant women should be, it should be emphasized that influenza vaccination is safe throughout pregnancy, and there is more need to take the vaccination during pregnancy in this pandemic. While attending patients in person, the staff should practice um, adequate personal protective measures as well by using such equipment and ensuring that both the patients and the attendants and the visitors who are accompanying the patients should be wearing face masks, should be practicing physical distancing, especially in waiting areas. They need to be organized. So, and जिस तरह से we are wearing our clothes, जिस तरह हम शलवार कमीज पहनते हैं, अब उसी तरह से face mask भी पहनना है. That is part of our dressing up now. And that should be ensured while the patients are visiting us as well. The impact of the pandemic had a fallout not only on physical health, not only on financial impact, economical impact, it has had a great impact on the mental health of the general population and generally, and specifically on pregnant women as well. There has been evidence and reports that mental health issues have been encountered more so during the pandemic in pregnant women. There has been a rise in domestic abuse as well, with obviously the financial impact the pandemic had and the economic fallout it had. So it did have all these issues, and these need to be addressed whenever an antenatal appointment is there. The pregnant woman needs to be assessed for mental health and whenever needed, managed appropriately and referred whenever concerns arise. So when a pregnant woman thinks that she has been exposed or she experiences symptoms which might be pointing out towards COVID-19. In that particular case, she should be calling her maternity care facility, health facility. Abroad in the Western world, in the developed countries, the networks and the hospital health and the health system is so that they can easily organize this calling and everything. But in here, in Pakistan, private in the private setups, yes, they can call the facility, but for the public sector hospitals, that is not possible. And for this, helplines were made and they were working really well. In Islamabad, the number was 1166. In Rawalpindi, the helpline was 1033. And the operator would inquire about the symptoms, and after triaging, the operator will inform the district health officer to arrange for collection of diagnostic swabs from home, and then further management will be decided under the supervision of the district health officer. Those patients who have mild symptoms or who are asymptomatic but were exposed and found to be COVID positive, they are generally recommended to self-isolate for about 2 weeks. What does self-isolation mean? Not going to work, public places, schools, avoiding public transport, avoiding visitors, staying at home, ventilation, and all the measures that have been advised to the general population as well. As for the maternity appointments, the routine maternity appointments, they need to inform their maternity care provider regarding self-isolation and seek advice on attendance. However, whenever there is urgent obstetric or medical care required, they are encouraged to call the maternity unit if possible in the first instance. But if that is not possible, they should attend the health facility, visit the health facility. And they are requested to travel by private transport instead of public transports. And prior to entering the hospital, they need to inform the reception that they are suspecting that they might be having or they are COVID positive, so that proper infection control measures can be adopted. If they need to call an ambulance, the call handler should be informed that the woman or the member of her household is symptomatic of COVID-19. Attending women who are suspected or who have confirmed COVID-19, they should be attended by staff in appropriate personal protective equipment. And they should be offered surgical masks, which should not be removed until and unless the woman is taken up to the isolation room, to the isolation ward, whichever in the facility which is designated for this purpose. And ideally, these facilities should have en-suite bathroom facilities. Preferably, room should have negative pressure, and only relevant staff should be going to those isolation areas. Steroids for lung maturation, wherever indicated, can be given. And once the patient has recovered, there is no additional, they should revert to the routine antenatal care if it was mild to moderate COVID disease. However, in those patients who had acute illness and needed hospital admission, fetal growth surveillance through growth scan is recommended 2 weeks after the illness. Venous thromboembolism is considered to be a transient risk factor in COVID-19 pandemic. And this should trigger reassessment with multidisciplinary approach. And women who are staying at home should be advised to hydrate themselves well and remain mobilized throughout the period of isolation. However, those patients who need admission, they require prophylactic thromboprophylaxis in the form of low molecular weight heparin. And patients with severe complications of COVID-19, they need a multidisciplinary approach for a decision regarding appropriate dosing regimes of thromboprophylaxis. Once the patient has been hospitalized and then discharged, she should be advised to have thromboprophylaxis for 10 days at least later on. During the intrapartum period, that is during the period when the patient is in labor, routine care should be offered in those patients who are asymptomatic. And most of the patients are asymptomatic, as we just discussed earlier on, that 75% of the patient are asymptomatic. But if the patient is symptomatic, they are advised to call the maternity facility when they are in labor, preferably call if possible. But in Pakistan, this is not possible all the time. So if the patient presents and she has mild symptoms and she has a private transport available to her, she's advised to remain at home or go back home till the time she's in established labor. And once in established labor, then symptomatic patients need to be managed in hospital facilities. And ideally, they should be provided maternal and fetal assessment in the same isolation areas which are designated for the purpose. Obviously, multidisciplinary care should be there. And in addition to the routine standard maternal and fetal observations, oxygen saturation needs to be monitored as well, which should be aimed to be above 94%. Symptomatic patients need continuous electronic fetal monitoring. During intrapartum care, if a patient is symptomatic with signs of sepsis, then the whole protocol of sepsis management should be used or should be followed. With COVID-19 as a differential diagnosis. Not all fever during labor will be because of COVID-19 during the pandemic. That is a very important message. Patients with moderate chest symptoms should have strict fluid balance because fluid overload has to be avoided as coronavirus has some myocardial insult as well. Now, about birth partners and attendants. Obviously, restrictions on visitors should follow local hospital policy, but where birth partners are allowed, they should be supported and encouraged because it is seen that having birth partners improves the outcome of labor. Obviously, with infection prevention and control measures, with face masks and not moving around the hospital, remaining beside the women, and frequent hand hygiene and respiratory hygiene. However, every birth partner needs to be asked at the time of attendance whether they have had any symptoms suggestive of COVID-19 in the previous 10 days. If they have had it, then they need to be told and asked and requested to leave the health facility and go for self-isolation at home and seek further advice regarding that. If a patient has COVID-19, then elective delivery, if possible, if safe to delay, should be delayed till the time the patient is self-isolating. But if it is not safe to delay, then obstetric management should be according to the usual protocol. However, multidisciplinary approach with the inclusion in the team of an anesthetist, of an intensivist, of an infection control specialist should be ensured. The mode of delivery is not influenced by the disease unless and until there are respiratory conditions, there is severe hypoxemia which needs or demands urgent delivery. The second stage of labor at times need to be electively shortened by use of instrumental delivery in symptomatic patients who become exhausted or have hypoxia. And whenever a category 1 cesarean section is done, the patient should be informed previously as well during the antenatal care period that wearing the personal protective equipment is a time-consuming process which might as well have an impact on decision to delivery interval. However, evidence till now has shown that this impact is not significant. Pain relief in labor should be continued, and if Entronox is used, then single microbiological filter for personal use of the patient should be ensured so that contamination is not there. There is no contraindication to regional analgesia or anesthesia. In fact, epidural analgesia is recommended early in labor in women who have suspected or confirmed COVID-19 to minimize the need for general anesthesia in case of urgent delivery. Whenever there is an obstetrical or medical emergency in a patient who has confirmed or suspected COVID-19, then obviously multidisciplinary care along with infection prevention and control measures should be carried out. but the obstetric emergency need to be dealt as a priority, and we should not be waiting for the results of COVID-19. Wherever chest imaging, which is very important in patients who have respiratory symptoms in COVID-19, X-ray as well as CT chest, HRCT, that should be kept performed and not to delay due to fetal concerns. In fact, fetal protection measures such as use of lead shields should be carried out. I will again emphasize that all the differential diagnosis should be considered when patients have symptoms which are suggestive of COVID-19, because many a times there is an overlap of symptoms, and we should we should not have a tunnel vision and treating COVID-19 only. We should consider all the differential diagnoses while attending patients during this pandemic. So, and then COVID-19 disease has an impact on the cardiac function of the patient as well. So ECG, echocardiogram, CTPA, whatever is needed needs to be performed. Many a times there is superadded bacterial infection, and so if the patient has COVID-19, although it is a viral disease, antibiotics need to be given because of the immunosuppression and immune modulation, the patient many a times have superadded bacterial infections. The primary practice is to prioritize medical care in order to stabilize the woman with standard therapies for the management of COVID-19. The antiviral remdesivir is currently subject to a therapeutic alert for pregnancy, but when the benefits outweigh the risks, it can be given. Obviously, a multidisciplinary team has to be there, and a board should be deciding what to do and what not to do. So coming over to the neonatal care, all babies of suspected or confirmed women, confirmed cases of COVID-19, their babies need to be tested for COVID-19 as well. If the baby or the mother do not have any immediate um, critical care requirements, then they should be roomed in. The mother and the baby should be together. The benefits of breastfeeding definitely outweigh any potential risk of the of transmission, especially in our part of the world, where the number one cause of death in babies is diarrhea, infections. So the main risk for infants is of an infant who has a mother who is COVID positive is the risk of close contact, which might lead to transmission of infection due to airborne droplets. So this need to be minimized. All of this needs to be discussed with the mother, and the importance of breastfeeding with proper measures needs to be emphasized. The babies cannot wear masks. The babies cannot have face coverings, as there's a risk of suffocation. So it is the mother who needs to practice hand hygiene, uh, washing hands before touching the baby, before feeding the baby, before handling breast pump or bottles, avoiding coughing or sneezing on the baby, wearing a face covering, a fluid resistance mask while handling the baby, following recommendations for pump cleaning if it is being used, and when the mother is not so well and does not feel like putting the baby to the breast or latching the baby. In that case, she can express milk, and somebody who's well can then feed that milk to the baby. For the pregnant healthcare professionals, now healthcare professionals is one of the occupations which is high risk for exposure to COVID 19. So, pregnant healthcare professionals at any gestation should be offered the choice of whether to work in direct patient facing roles during the coronavirus pandemic or not. However, if they're less than 28 weeks, they should practice social distancing but can choose to continue working in a patient facing role, provided the necessary precautions are taken. However, pregnant healthcare providers who are more than 28 weeks or are high risk, have underlying health conditions, they need to avoid direct patient contact, and it is recommended that they should stay at home. So, with this, we wrap up. And the key points that we discussed right now was that the most important thing is that the healthcare providers should not only practice strict infection prevention and control measures, but they need to make the population and the pregnant ladies aware of it. And the good thing is that the fetus is unlikely to be exposed during pregnancy, and women with symptoms suggestive of COVID 19 should be advised to self isolate as per the national guidance. If an emergency, before attendance, they need to phone uh, any helpline which is available in their local areas. As in Rawalpindi, it is 1033, and in Islamabad, 1166. Symptomatic pregnant women need to be identified promptly and treated accordingly. Thank you very much.
Thank you very much, Professor Dr. Shamsunisa Sadia. I must say that's a very, very educational teaching session. In fact, I have learned a lot, despite of the fact I'm a pediatric surgeon, but you have educated me just like a common man. And I am pretty much sure that quite a few people has learned a lot from your uh, teaching session. In fact, while you were teaching, there was question starts, pouring in. So I was just, writing down the question that what I need to ask at the end of the session. But thank you very much. Now, can I request Dr. Kafil Shadani, who is a consultant pediatrician in Letterkenny University Hospital, Ireland, uh, to give his talk, please? So, Dr. Kafil, can you start sharing your slides and start your talk? Thank you.
Dr. Kashif, thank you very much for giving me opportunity. It's really a great pleasure, and I will try to be more specific and summarizing rather than going into more details, not replicating the whole knowledge. Regarding the COVID-19, as all of us, we are aware that the disease started in November 2019, and in the end of 2019, in the media, it got a lot of attraction. And WHO first time declared as a COVID-19 disease in February 2020, and in March 2020, it was declared as a pandemic. A lot of studies have been done in this area, as we all are aware. So we are not only fighting with a pandemic, we are at the same time fighting with an infodemic as also. So we need a little bit care once we are analyzing the data and the studies. So in the pediatric age group, if we talk about the epidemiology, the children are less affected compared to the adult populations. Overall, among the infected people, the children's ratio is only 13%, and 2.4 to 4% of the children will need hospital admission. Among those who are admitted in the hospital, only 1/3 needs intensive care service, and 7% of them will need intensive ventilatory support. A large study in United States involving 5,000 children in the age group of 0 to 9 and 12,000 children from 10 to 19 years. The most common clinical presentation was cough, fever, and shortness of breath, almost up to 63% of the presentation. And if we break it down, then the fever was predominantly in 46%, cough up to 37%, and shortness of breath up to 7%. Other clinical features like abdominal pain, vomiting, sore throat, myalgia, and change in taste, they were less in number, so ranging between 10 to 15%. In the bigger children, which are in the age group of 10 to 19, again, the common presentation was fever, cough, and respiratory distress in a combination of 60%, but the cough was more predominant compared to the younger population, up to 41%, and the fever was in 35%. Another important difference among the older age group is the headache, which is almost in 41% of the children, and sore throat and myalgia, which makes up to 30%. The other clinical features like myalgia, sore throat, abdominal pain, nausea, vomiting, diarrhea, and rhinorrhea ranges between 6 to 15%. Loss of taste was not a common presentation in the hospital admitted patients. Either it was not the main concern for the hospital admission, or in the studies it was not included that much. If we talk about the severity of the disease, most of us in the media have heard about multi-system inflammatory syndrome. Another name for that is the pediatric inflammatory multi-system syndrome. Those children who are severely affected, this is the entity now given the name. It is quite similar to the Kawasaki disease for those of my junior colleagues who have worked in pediatric, or the presentation is similar to the toxic shock syndrome. Clinical features may include fever, myocarditis, rash, and hypotension. And the 40 to 50% of the children, they can have a diagnostic criteria which can fulfill the typical Kawasaki disease. Risk factors in the pediatric age group are almost similar to the adult age group: obesity, severe genetic and neurological disorders, inborn errors of metabolism, sickle cell disease, underlying cardiovascular, respiratory, or renal issues, diabetes, and immunosuppression. Routinely, we do the basic workup for the mild to moderate children the similar way as we do complete blood count, urea electrolyte, liver function tests, and in most of the children, the results are normal, which are the mild presenters. Leukopenia and lymphopenia was in 13 to 17%. A mildly raised creatinine kinase and transaminases was observed in 13 to 15% of the children. LDH and the other blood workup in the multi-inflammatory syndrome, they were close to the adult population presentation. I'm talking specifically about troponin, ferritin, LDH, and the coagulopathy. A systematic review of more than 600 children in United States, they reviewed about the specifically imaging. 50% of the children, they had the normal chest X-ray finding, In CT scan, again, 1/3 of the children, they had the normal findings. Only 1/3 or up to 30% had ground glass appearance, and 1/4 had unilateral and 1/4 had the bilateral changes. In Italian studies, they also utilized ultrasound of the chest, and they found subpleural consolidations. Why the pediatric age group is less affected and they have less severity of the COVID disease? Overall, there is no consensus so far, but the different studies have given few indicators which can support why the children are more protected. So less intense immune response to the virus itself, less viral load, and different expression for ACE2 receptor. And the other common things which were found in few of the European studies were that they had an underlying cross-reactivity antibodies, that was they were protected, and they had the live vaccine compared to the adult population. That's why they were more protected. And as we all know that the children are more healthier regarding their blood vessel and the cardiovascular issues. So end organ damage was observed in those with the multi-system inflammatory syndrome, especially cardiovascular-wise myocarditis, heart failure, and renal failure, and then different complications of the cutaneous. But the most important is the neurological area, where they can have a wide spectrum of complication ranging from encephalopathy and encephalitis in the form of ADEM, which is acute disseminated encephalomyelitis, and to different forms of peripheral nervous system involvement in the form of Guillain-Barré syndrome. In one bigger study in the UK, in Liverpool, 80% of the children had encephalopathy, 40% peripheral nervous system involvement, 35% headache and behavioral issues, and only 13% had focal seizures. Compared to the adult population, the children had less incidence of stroke and psychiatric issues. I have shared few of the slides from the radiology. I will not go into the more details. The one on my right side is for Adam, for a 116-year-old child from the Asian background. And the left upper side is the splenial changes, which is another common finding in the literature. They have a reversible changes on the T2 signals. And the lower MRI scans, they are from a Guillain-Barré syndrome, the child of 18-month-old, post-contrast enhancement of the nerve roots. And luckily, all three children, they recovered, and only mortality was in one child out of 23 in this series of patients. Psychological and the social impacts we cannot ignore. According to the UNICEF and WHO, that 150 million children had a restricted access to the essential healthcare services. 188 countries imposed closure of school, affecting learning in 1.86 billion children. And we all hear about the online education system, but according to the WHO and the UNICEF statistics, that 31% of the children, they don't have access to outreach and broadcast system, which affects more than 460 million children globally. Nutritional programs offered by UNICEF were also badly affected, and the children did not have a proper access to immunization, which imposed an extra threat, leading to more than 2 million deaths in children under the age of 5 years, which is more than the previous year in 2020. And violence, exploitation, and abuse are the other concerns, the children were at more risk globally, targeting 1.8 billion children. So in a summary, the children are affected in less number compared to the adult population, and few of them need hospital admission. And the clinical presentation in the pediatric population is different than the adult population. In the severe forms, there is a well-known syndrome called multisystem inflammatory syndrome, or PIMS, and the children who are affected in this cohort, they have more complication. Neurological complication are have quite wide spectrum, ranging from Guillain-Barré syndrome in the peripheral nervous system to acute disseminating encephalomyelitis and encephalopathy. Psychosocial impact is also important, increasing more poverty and less healthcare facilities, increasing morbidity and mortality. Thank you very much. We will try to take the questions. Over to you, Dr. Kashif.
Yeah, thank you very much, Dr. Kafil Shadani, for your nice, presentation. I think so that I'm sitting in the galaxy of stars today. Such a nice presentation with full of information and everything. Uh, Now, the good thing is that despite of the fact that Dr. Shai Salimi is not able to come and give us any kind of presentation, he has kindly arranged a consultant neonatologist to speak on his behalf, so that we covered that neonatology aspect of and the pediatric aspect of this talk also. So can I kindly introduce Dr. Muhammad Islam, who is a consultant pediatrician with a special interest in neonates from Ireland, to give his talk. Dr. Islam, the mic is yours and the screen is yours.
Thank you, Dr. Kashif. There was wonderful talk from Dr. Shamsun Nisa and Dr. Kafil. So I won't take a lot of time because there are so many previous good points. I'll focus on the neonatal aspect, and I'll try to share one recent study that is basically systemic review and meta-analysis recently published last month on 1st January, and that data is from up till mid 2020, and it's summarize all the previous published studies. So I thought I'll share with everyone, because rather than going everything again. So can you see my screen? Can you hear me, please?
We can hear you.
Okay, sure.
But we can't share your screen, see your screen. So if you can share your screen.
I'll go back just 1 second. Now?
No, we can't. Yeah,
I think something is happening. Yeah.
yeah, it's happening now. Yeah.
Okay, so I just talk about myself. So I'll go with coronavirus and neonates, and what neonatologists need to know, and what as Dr. Shamsun already mentioned. So this is basically the recent study that is published on January 1st this year in the infection and disease, and that is from Mr. Di Taro, impact of COVID-19 on maternal and neonatal outcome. And if we look back so far till they collected the data, there are around nearly 1800 study published on these topics, and there was so many repetition. And if we look, there was after screening they found 878 studies. Then further down, and they actually included 23 study on this meta-analysis. And what they found is quite interesting. And as Dr. Shamsun already mentioned, overall they found there were 3 stillbirths and 5 maternal deaths that was reported during whole period. And then the prevalence of COVID-19 related admission to neonatal unit was only 2% among all. And what they found, there was 444 neonates who was positive with COVID-19 RNA at birth. But there were total was 414 birth, but there was only 19 who was positive. That comes like one every 23rd baby who is born to COVID positive mother, baby will be positive. Now there was they did these one with the RNA, and there was one child whose swab was negative, but still they found elevated IgM and IgG levels antibodies. And interesting thing, they noted that there was a lot of, and there was very high cesarean deliveries during this period, although there was no clinical evidence supporting this mode of delivery, as Dr. Shamsun already mentioned. And they also noted that indeed, in most cases, the disease does not threaten the mother, and vertical transmission has not yet been clearly demonstrated. Therefore, COVID-19 as such as alone should not be considered as indication for elective cesarean section. There was another interesting thing they noted, that there was a lot of preterm deliveries, and in one study they noted there was around 47% preterm deliveries. However, these were the COVID positive mother, and there are, as we know all, there are so many other risk factors for preterm deliveries, and as Dr. Shamsun already mentioned. Okay, now what and the interesting thing was, there was only 2% kids who needed admission. And now, if we are unnecessarily admitting these kids, basically we are compromising few things. And the most important is their feeding, and then mother and baby relation, and their skin to skin contact. Now, especially in our developing countries, Pakistan, and even when they say if mother is positive for other infectious disease, don't separate the baby and give them mother feed. And this is more important here, when we have already 44% stunted growth due to malnutrition and that stuff. And this is a very important source. We are not separating the mother and baby, and we are keeping them for breast milk. Another thing, interesting thing was breast milk, either because it's not common practice in Pakistan or developing countries, but in European countries, as we all know, there is common practice of donor milk and then mother milk. So this is very important for there are so many benefits for breast milk, and one of the most important benefit, as we know all, it prevent severe necrotizing enterocolitis. And we have an if we enable these policies and support the mother and encourage them to breastfeed even they are positive with COVID, and keep the baby and mother all together and close to each other, we can definitely decrease these complications. And this has as multiple studies has shown it effectively, how milk, and especially the mother milk or donor milk, breast milk, decrease these, rather than putting these babies on formulas and then they are ending up with severe complication. And especially in our country, we all work there, and we know the resources, and then and how if they are gone into severe necrotizing enterocolitis, then the chances of mortality and morbidity are very high. So I can't as everyone know, I can't stress any more about these benefits. And another benefit about this is mother and baby contact and skin to skin contact, and especially keeping temperature of the baby with skin to skin, or we call it kangaroo care, and preventing hypothermia and all hypothermia related complication of hypoglycemia, infection, respiratory distress syndrome, and all further complication. And they also noted another interesting thing. There are more and more stories, if we read on net and other studies, due to COVID, knowingly or not non-knowingly, suspected or unsuspected, like mother and babies are given very limited time, and that is like because we are taking some time in the beginning of this COVID pandemic, we were taking all the babies, admitting them and those stuff, although the practice is very changed now, but there is still like we need to think about that. And that like we need to remember one thing, and that is very important, because this pandemic will finish, it will go away. Like if you will read the history, like all the previous pandemics and everything, this will go away. How many years it take, how many months it take, we don't know, but it will go away. But the implication this pandemic has on our health, our personal health, our personal life, development of children, and they will be long lasting, and we need to be very clear about this stuff. And we like any intervention we are doing today, we need to think about the long term effects. And I'll finish my talk with that, and thank you very much. Any questions, welcome.
Thank you very much, Dr. Muhammad Islam. That was a very informative presentation, which focused on the neonatal aspect of COVID-19. Now I'd like to introduce Dr. Kashif Chauhan, who is a pediatric surgeon in United Kingdom and has been leading the efforts to bring together the Pakistani diaspora and help the local community. I'd invite Dr. Kashif Chauhan to share his experience and views about COVID-19, please, and guide us through the Q&A session as well, please.
Thank you very much, Dr. Mubashir, for your introduction. Thanks a lot for that. I must say it was a very informative session, which I've listened to it. I'll just shed my experience a bit because we are already running out of time, and I've got a list of questions to ask from our guest speakers. Pediatric surgery during the COVID-19 periods, during the COVID-19 pandemic, has evolved also. We have learned so many things about the neonates, about the children, that how to deal with them. We never stopped our surgical intervention on all the children who needed the surgical intervention, even on those ones who becomes out to be COVID positive. It is extremely important to realize that even your patient is COVID positive, it is our prime duty, prime responsibility to treat it and to operate on it. So it has never changed a bit, despite of the fact, even if it's a COVID-19. I'll just say a few of those words. And now I've got a list of questions to ask, because there are quite a lot of questions coming on the thing. So can I start the question answer sessions with Professor Dr. Shamsun Nisa Sadia, please? The first question, Professor Saab, for you is that, can the pregnant and lactating woman be vaccinated? I think so. This is a very relevant question. So if you can please answer that question.
Thank you very much, Dr. Kashif, for the question. And yes, it definitely is a very relevant question. So with the arrival of the vaccinations now, pregnant women who are at risk of catching coronavirus more, those pregnant women, such as pregnant women who have public facing occupations, especially who are healthcare providers, the need for vaccination can be offered to them and discussed with them. And this is what is being done for the AstraZeneca and the Moderna vaccines. However, the Sinopharm vaccine, which is available in Pakistan, that is contraindicated for pregnant and lactating women. So high-risk pregnant women or lactating women who are like more prone to catch the virus may be offered the vaccine which is the Oxford one, the AstraZeneca or the Moderna vaccine, but not the Sinopharm.
That's very good, so nice of you. That's, I think so. You've explained it really well. I've received a question from one of the ladies. She hasn't mentioned her name, but referred as and she's concerned about two things regarding. You have raised the question of COVID, and she had raised it that is the risk of miscarriage increased in ladies who has the COVID-19 vaccination as compared to the ladies who do not have COVID-19 vaccination? And the same thing she has asked, that is the risk of miscarriage increased in the patients who have got COVID-19?
Yes, thank you very much. This again is a very relevant and very important question. And pregnant ladies who contract the disease, they're very concerned about their baby's health. And the data collected to date does not indicate that the rate of miscarriage is increased in pregnant ladies with COVID 19. As we just discussed, that COVID 19, it has not been shown that COVID 19 leads to congenital anomalies in the baby and does not affect the fetal development. And since the most significant cause of miscarriage is chromosomal abnormalities and fetal developmental abnormalities, so this is it is reflecting in the incidence of or the prevalence of miscarriage in the data collected to date. So yes, this is evolving data.
Thank you very much for that. I've got another question, Yun, for you. It looks like that your talk has, mobilized, quite a lot of, ladies who are either pregnant or who are in the process of getting one. There's another question regarding COVID-19 and stillbirths. I think so. This is a very relevant question. This says, is the risk of stillbirth increased in the patients who has got COVID, or in the ladies who has got COVID-19 positive?
So again, the data collected and the evidence that we have to date does not indicate that the risk of stillbirth is increased in patients with COVID-19. And I'm sure Dr. Mohammed Islam will second me in that the rate, the perinatal mortality rate and the perinatal morbidity rate has fortunately not been impacted so much by the COVID-19 pandemic.
Thank you very much for that. I've got just a few more questions, but I've got two more, guest speakers. So I'll just give them the chance also to answer the question. So can I go to Dr. Kafil Shadani, please, to answer a few questions which I have with me?
Sure.
Yeah, so Dr. Kafil Shadani, this is a very burning question. This is a very important question, which is all over the place. And I have received 1, 2, 3, 4 questions regarding the same, thing. So I will just combine all those 4 questions to one question. The burning question is that how effective is the vaccine in relation to the mother and in who are, going to give birth to the children? Are the children's be acting as the mothers are acting as a transmitter of disease to the children's if if they are COVID positive or if they don't have COVID-19 vaccine? So what is the effect of that vaccine?
Dr. Kashyap, very interesting and definitely a burning question. But to my understanding, in the data, the Pfizer vaccine, they did in their initial process of safety, they did not have this answer so far, that the pregnant women and the immunodeficient people, they were included in that study. So we cannot safely say that how much it is. But regarding the prevention, they claim that the incidence of severe COVID disease in those who got the vaccine, it is 95% protective in two of the vaccines. And in the lowest protective has been claimed up to 70%. But again, this is about the severity of the disease, not the spread to the other people who is the asymptomatic one. This has again not been studied, that how much the person who himself has got the vaccine, is he not spreading the same infection to the other people? This still has not been studied, but they themselves, they are definitely protective up to 95% in most of the vaccines. The lowest protection rate is the 70%.
Oh, thank you very much. That's a very precise and nice question. Following the same thing, there's another question which just popped up after while you were explaining this. This is there any role of medications in preventing COVID-19?
In the pediatric age group, I will say no, none of the studies has suggested to take any medicine which can work as a preventer. Yeah.
Thanks a lot. And then in your presentation, there was you talk about multi-system inflammatory condition and Kasai disease. That is very nice. But if you can explain how to differentiate between Kasai disease and multi-systemic inflammatory syndromes, because in COVID patients, both of those diseases can interrupt with each other, and it is sometimes become difficult to diagnose whether the child has got a COVID-19 with Kasai disease or COVID-19 with multi-system inflammatory symptoms. So what are your thoughts about it?
I think your question is regarding Kawasaki disease.
Oh,
Kasai
sorry.
procedure is in the pediatric
Exactly.
surgery.
Sorry.
Kawasaki.
Disease. My
Kawasaki disease. Okay. Yeah. No, I got it. So Kawasaki disease, Dr. Kashif, is the one which usually we see as a pediatrician in the Asian population, and it affects the younger age group up to 5 years. And this multi-system inflammatory syndrome has some geographical and dermographic changes, that the age group involved is a relatively older age group, and the ethnicities are the Hispanic and the Black populations more compared to the Asian population. Interestingly, the first case studies came from UK, and then the case series up to 50 children again from UK, followed by a lot from the European countries, America, South Africa, and in Ireland as well. But we did not hear from China the similar type of increase. Coming back to your question that how we can differentiate, still in the multi-inflammatory system in a syndrome, 40% of the children, they fulfill the criteria of classical Kawasaki disease. Kawasaki disease basically presents with conjunctivitis, lymphadenopathy, rash, and the main complication is on the heart, especially the coronary artery disease, which gets dilated, and we use the word aneurysm for them, and the treatment is immunoglobulin. The same cohort was treated similar to the Kawasaki disease with the immunoglobulin, but the severe forms were, again, they were treated along with immunoglobulin steroid as well.
Thank you very much, Dr. Kafil. That was a very, nice answers of your questions. I've got about another three questions for you, but I'll move it to Dr. Muhammad Islam. Uh, Dr. Islam, I've got a question that you have mentioned a word by the name of kangaroo care. Would you mind explaining what does the kangaroo care mean?
Thank you, Dr. Kashif. This is basically the care, skin to skin care. Like, if we have all seen the kangaroos, they are keeping their babies in the pouches or smart pellets. This is when we say kangaroo care, this is basically alternative to incubator care in preterm babies, and basically keeping the baby warm with skin to skin contact with the mother.
Thank you very much. Now, following this question, somebody, let me see what they have written. Okay. Now, following this question, they have written, if you are saying that the kangaroo care is the skin-to-skin contact, will the newborns will be given this opportunity to have a skin-to-skin contact with the COVID-19 positive mothers?
Yes, as we already mentioned, like we have they are allowed to breastfeed. Okay, they are allowed to breastfeed if they are well. Baby mother is well. They should stay with the mother and should get the breastfeed. And same is the with the even with skin to skin contact. As we know, it's very limited. At almost no data suggesting there is transmission from skin to skin. A very little one. Okay, if they are allowed to breastfeed, they are allowed to have the same kangaroo care and same even with the positive COVID mothers.
Thank you very much, Dr. Muhammad Islam. That's, I must say, it's a very nice, educational sessions which we all have, been a part of it. And I must say that all of us, has given or are doing what we can for the community and for everyone. Uh, I've got quite a few other questions, but I will send those questions individually to all our guest speakers to answer them, because we are running, short of time. We have already proceeded about more than 20-25 minutes. And I must thanks Professor Saiba, Dr. Shamsun Nisa Saidia, for your valuable time. I know you were committed to another sessions, but you have cut short that sessions to join our sessions. So on the behalf of APPS Europe, Not Fund Yarane Watan, we are really grateful to you. Special thanks to Dr. Muhammad Islam to chip in at the last moment, because one of our colleague, Dr. Shah Salimi, has to go and treat the patients in the COVID-19. So thank you very much for that. And lastly, Dr. Kafil Shadani, who has given excellent presentation on the topic and answered few very hot questions regarding effectiveness of vaccine and what prevention which we'll take. So I'm really thankful to all of you to be a part of that thing, and I'm thankful to the federal government of Pakistan, Yarane Watan program, for helping us live telecasting it in their institutes also. If there's any questions, even after the presentation, you can write it down on our Facebook page, and we will try to answer it as much as possible. So thank you very much, everyone, for their session. And then Allah Hafiz.
Allah Hafiz.
Thank you.